happy Wednesday. Today Meg and I are going to be vlogging a PT focused day in the life, and so typically on these types of vlogs we try to talk to you guys more about our work day, record clips if we are able to, and just kind of generally talk about what it's like to work as a physical therapist. I am getting up to go work out before work today. It's 5:40. I got up at 5:30, and hopefully I'll be in the gym by 6 o'clock. Good morning, guys. Happy Wednesday. Today Sierra and I are doing a video where we're vlogging a day in our life, but we're doing it more specifically as physical therapists. We'll talk a little bit more about patient care, the types of diagnoses we're seeing, things we're doing for treatment. Obviously HIPAA, we need to make sure we're not, giving away any sort of identifying patient information, and we can't really record at work, but we'll do our best to still provide some educational content for you guys. So I am getting ready this morning. I got up around 6:30. I'm probably going to try and leave my house around 7:20 or so to drop Vegas off, and then I'll head to work. Vegas goes to daycare today. But I'm trying to think of, while I'm making breakfast, I'll probably find some sort of topic of conversation that I think would be helpful just to discuss with you guys before work. But we've also done a couple of videos like this in the past. So I'm going to, not belabor any of those things that I've talked about in the past and find something new to talk about. Crazy, you guys, if you've been watching Sierra and I for a while. Yesterday morning was I renewed my physical therapy license for the first time, which is just crazy to think that I have had my license for over 2 years. You have to renew it every 2 years, and it goes based off of your birth month, so you can renew it, mine would expire in August, but you can renew it 60 days prior. So luckily for the first renewal, I'm sorry, you can hear Vegas chewing on his bone. For the first renewal, you don't have to do any continuing ed stuff. So any of the continuing ed stuff that I've done up until now can count towards the next time I renew my license, which isn't until 2027. But yeah, I got to do that for the first time, so that was weird. Sierra has ordered our she's ordered our V8 drinks that we like from Amazon, so eventually we will have some more. But in the meantime, I'm still using these packets and putting them in my water. I'm gonna watch some YouTube while I eat my breakfast. This is one that this is something I know we've talked about in every single video we've posted like this, but I feel like it's worth repeating, so I'll try and keep it short. But it's helpful to know, if you've never seen me in there before, what type of physical therapy do we do, what setting do we practice in, because that informs what the rest of our day looks like. So Sierra and I both work in long-term care and skilled nursing as our primary setting. We do not work at the same place. We work at 2 different places with 2 different companies. So both of our facilities have what I would say is a continuum of care. If I can find a graphic, which I feel like I should be able to, I'll put it here. But it's basically, if people are living in a facility, they could be living in independent living, they could be living in assisted living, or they could be living in assisted living memory care, or they could be living in long-term care, and all of those are different tiers to how much assistance you need from caregivers day to day. Both of our facilities, not every facility has all of those in one spot, but both of the facilities that we work at do. And so primarily we are seeing, I would say, skilled nursing and long-term care residents. Skilled nursing, it means that they don't usually live there, but they came from a hospital because of being sick or getting injured. And they're there to do rehab and recovery until they can either go back home or move to a different level of care. That's the main thing that we treat. However, since we also have independent and assisted living residents that live in our facilities, they can also come do physical therapy on an outpatient basis at the facility, just like people who would go to an outpatient ortho clinic. So it makes things a little bit variable. It means that we're treating a lot of different things day to day. I have 6.5 hours of treatment today. I know at least one of those is outpatient, but there might be a couple that I'm forgetting. Actually, I think there's at least 2 outpatient people that I have. So those people are scheduled at times during the day that I work the rest of my patients around, but otherwise the skilled patients and long-term care patients, I just try to see whenever they're available and whenever I'm available. Just finished my workout. I'm getting ready to drive into work. It's 6:50. The good thing about working in this setting of skilled nursing and long-term care is that there's no really strict schedule, and so
I used to show up more like at 8:30, and then I decided like 7:30 was more of a vibe because then I could be done earlier. Some of my coworkers don't get in until like 9 o'clock, and so that is one nice thing about it, is that you can kind of control your day, or if you have like appointments and stuff, you can adjust your schedule if you need to. So like my dentist appointment that I had last week, I knew I had like a shorter day on that day, and so my appointment was at 3 o'clock and I didn't have to take any PTO or do anything, so that was nice.
Look at what happened to my deodorant because I left it, like it was super hot the other day and my gym bag was in my car. So look at what happened. I can't get it back in. Alright, I just got to work. It's around 7:45, so I am going to head in shortly. Sierra and I mention this all the time on our channel, but we are both paid hourly. We are not salaried. And so every day we show up to work, we get our schedule, we see all the patients, and then when we're done seeing patients, then we leave for the day. There's different things in terms of like productivity that most contracted therapy companies have that they don't want therapists to stray too far away from. So any non-patient care time that's not directly billable, they want to try and minimize that as much as possible. So oftentimes with therapy companies, you're looking at anywhere from like usually like an 85% productivity. So like for example, with my 6.5 hours of treatment today, if I stick with that amount of treatment time and I don't go over or under for anyone, then that should equate to like 7.64 hours worked. So that's in theory how much I will be here today, unless any additional admits come or something gets thrown, you know, and messes that up. But that's kind of the idea. I'll head in and I might try to catch up with you guys around lunchtime for a little midday check-in and maybe talk about my morning patients. I'm finishing up my lunch break. Wanted to do a little midday check-in. I will probably have to wait till the end of the day to talk to you guys like through my caseload and what I've been doing, because it's been a very busy morning and I quite frankly need to get back to work to see if I can get everyone in. So I'm supposed to have one group this afternoon, kind of waiting on one person to maybe get back from an appointment that's supposed to be in the group, because then I don't have to see them separately. So that's like the constraint that I'm working with. Otherwise, I've got a possible eval, part B, and then I think there's one person that I need to like finish more time with, and then one person I need to see individually. Okay, I kind of forgot that we had a working lunch today, so obviously I did not catch up with you guys during my lunch break to fill you in on my morning patients. So it's like 4:15ish. I'm gonna head home and I will do my debrief of the day at home with our actual nicer camera, and we'll talk through things. Today was, fair warning, I mean it was fine, but it was just one of those days where it's like, I felt like it was just so hectic and so busy. So like I didn't really get any just extra clips to add on to the story or anything like that. So I don't know, I might have to try and get creative a little bit with editing to make this interesting. Hopefully Sierra did a better job than I did vlogging stuff today. But like I got to lunchtime, I was like, oh yeah, I am supposed to be recording stuff for this video. We'll go home and we'll debrief. It is debrief time. I may or may not try to get additional like overlay clips of just me kind of role playing here like I'm at work. If not, we'll be talking. So first thing I do when I get into work is I get logged into my computer. I pull up the schedule for the day. I make sure if there's anything that needs to be changed, then I adjust it. Like there was someone on the PTA schedule that was actually discharged today, so I swapped that so it was on my schedule, because PTAs, if you don't know, they can only do treatment notes. They can't do progress notes, research, or discharges or evaluations. So I needed to switch those quick. There are people, like I mentioned earlier, if we're seeing them outpatient and they live in assisted living or independent living, we have set times that we see them. So I have a spot that I can go in on my schedule and put that in so that it prints out on my schedule. And I just like to have that on there. That way when I print out my schedule for the day, I can go in. I will go through and highlight any extra notes that are due, like if there's a progress note or research, if there's a discharge. And then I also go through and will highlight if someone is scheduled to be seen for either group or concurrent, then I will highlight that treatment time. And then I'll also highlight the specific times if they're scheduled to come in and be seeing me at a specific time, just so I can quickly pinpoint stuff on my schedule. Okay, let's run through the day. My first patient of the day actually lives in assisted living, but they are here skilled because of a recent fall. We had actually been seeing her before the fall, and then she came here skilled. Now we are going to have her discharged back to her assisted living apartment tomorrow, and we will pick her back up to see her for additional therapy. So we've mostly been working on strengthening, transfers, walking. We have been training, progressing back towards her 4-wheeled walker because she had been using a 2-wheeled walker. And I also had a progress note that I had to do on her today, which just means more paperwork. The second patient that I saw today, I had to kind of split my time with him because I had a 9 o'clock scheduled outpatient person. So I saw him for most of his time before then, but he is here because he had a fall and then hip fracture. So he had surgery on that. He also has dementia, so cognition's not super great and just requires a little bit more cueing. But he has been progressing well. We are trying to progress towards, we actually updated his transfer status today, so he's using the front-wheeled walker instead of our pivot disc for transfers with staff, and I did some staff training with them on that. Originally we were going to do stand pivot assisted 1 because he's been doing well with that in therapy, but the staff were a little bit concerned, and I always feel like if you can, try to bridge the gap a little bit and just make it so that the aides and the therapy team are all happy, that I am more than happy to downgrade, upgrade, to have assisted 2 still at least temporarily until they feel more comfortable with that. Then 9 o'clock I had my outpatient. This person lives in assisted living. We've been seeing her mostly for general weakness and strengthening and endurance, and she was a discharge today because she had met all of her physical therapy goals. Then I had a 10 o'clock outpatient. This person lives in independent living and they've had a couple of recent falls, so we've been seeing them for balance, strengthening, assistive device training, things like that. He actually has been progressing well in therapy. Then I decided, okay, it's 11 o'clock, I have an hour until lunch, I have a concurrent with 2 people scheduled, and I would love to get this done. So that was my plan, and I actually made it happen pretty smoothly today. If you don't know what concurrent is, it's just another form of therapy delivery where you're seeing 2 patients, at least for part of your treatment session, maybe at one time, but they're doing different things. In a perfect world, I would love to just do individual treatment all the time for all my patients, but therapy is a business, and so this is what we do to make the boss man happy. Nonetheless, I thought it was a good concurrent session. One of my patients I'm seeing, they're here skilled because of a recent back surgery and needing to work on transfers and progressing back towards prior level of function. Things have been kind of slow going. One of our biggest issues for progressing therapy is just this person has a lot of posterior lean and poor balance when they're trying to stand up. So a lot of our session is focusing on like anterior weight shift, finding your balance, and then obviously progressing gait and transfers as able with that. And then the other person that I was seeing for part of the same time, this is a resident that is typically in assisted living. They're here skilled because of, I think, hypoxia. I can't remember exactly why they went to the hospital, or if it was a fall, but they didn't break anything. I would have remembered that. So we've just been working towards progressing back towards prior level of function. She's been progressing pretty well as well. Then we had the working lunch and chatted about our caseload for 45 minutes or so, just to kind of get an update on what things we're working on, discharge planning for these people. If people need to discharge to a higher level of care, we'll talk about that during our discussion and meeting as well. And then at 1 o'clock, I had an outpatient person that I did a research on. A research just basically means like insurance had approved this window of therapy from here to here, and now we're outside of that window, so you need to resubmit approval for, you know, newer dates. This person's insurance has also been like allowing a certain number of visits rather than me requesting like a set frequency for this many weeks. We were seeing her originally for bilateral shoulder pain, so our plan originally was focused on that. She had a fall 2 months ago though, that then kind of changed what we were working on and adjusted our plan of care. And so today we did a research again, kind of readjusting our plan of care again, just to really be like, okay, if we are having to really put a close on therapy just because insurance continues to cut her off, like what kinds of things can we do to make you feel satisfied with your progress? So we're kind of leaning into compensatory stuff. And so what I mean by that is like her biggest concern is she wants to be able to stand up from any and all chairs, specifically dining room chairs, to be able to get up on her own without having to wait for staff. 8 times out of 10, she is independent with that, or she is able to like use the table nearby to help out with that. But she's limited because of shoulder pain and just strength, where sometimes she's just not able to stand up and she needs like an assist. So I am having her order, and this is like a new thing for me too, like I have been trying to be more comfortable offering compensatory stuff and kind of like providing additional resources for patients rather than just straight up therapy stuff. I mean, that's obviously ideal, but like this person just like has been on for a while and like we need to do something. So I found, and I'm gonna have her order a portable seat cushion to see if those couple extra inches will be beneficial for her to be able to stand up out of the dining room chairs. So we can practice with that. She liked the idea. It like folds up and has a little handle. So I was like, maybe we could get like a carabiner or something to put it on your walker so it just like hangs out with you and you can bring it with. I don't know. But she seemed intrigued with the idea and was satisfied with the goals that we had come up with. So I felt pretty good about that. Then I went and saw a skilled patient. I can't remember if she was admitted for a fall. That's what's coming to my mind, but she didn't like have any major injuries or anything like that. She is pretty much at her baseline or really close to it. She's discharging tomorrow from therapy. So I had a pretty just standard normal treatment session with her. We've been working on balance, standing endurance, wheelchair mobility, transfers. She was at memory care AL prior and she's appropriate to return back to memory care AL. So discharge tomorrow. Then I went and did a discharge today for someone who is returning to assisted living. She'd met all of her therapy goals. She was like, we were okay making her independent in her room with the walker as of today. But she was still technically wanting to have staff assist her, and she obviously has that level of support available to her in assisted living. So we kept her at that, but she was independent with all of her transfers and walking and bed mobility in the room. So that was good. That was a pretty smooth discharge. I actually shortened my time on that a little bit because I had an evaluation that I was trying to get to. Okay, then I went to try and see a skilled patient who I believe they were admitted for sepsis. They've been doing really well. Their plan is to discharge from therapy Friday, but they're already independent in the room with the walker. I went to go see her today. She's a very cheery person and she is like her own POA. Cognitively, she's with it. She just wasn't feeling the best today. I offered and provided education for a lot of other things we could do, but at the end of the day, if someone is not feeling the best and they are of sound mind and they can refuse therapy, like I'm not going to force you to do therapy. So she politely declined and refused me today. Then I went and finished my day by doing the skilled eval that showed up. They were admitted to the hospital because of acute respiratory failure. So my evaluation with them was mostly just focusing on transfers, monitoring vitals. She was not on oxygen, but she was desetting with activity, but nursing was already aware of that. That seemed to be par for the course. So provided education on that, what therapy is going to look like, what our goals are for her to return home, and then provided updates for transfer status for the staff to use there. Then I finished my little documentation stuff at the end of the day, and then I was done for the day.
I feel like I had a day today. And look, this pimple was not here this morning. This came on today. It must be related to the chaos of the day. But I will talk through all of my patients and kind of what I generally did, because that's the purpose of this video. But today was rough. I worked like 8 hours and 40 minutes. Started with a Part B. I think Megan and I have explained this last time when we were doing like Part B versus Part A. In this skilled nursing and long-term care world, any of the residents who live at the facility full-time that are seen for therapy are seen under Part B, which is like Medicare, and that basically just means it's like outpatient, but since they live here, like this is their outpatient. And then Part A is the people that are skilled that come from the hospital and like are planning to either return home. Some of them end up staying here long-term care or going somewhere else long-term care, just depending on their progress. So my Part B person I started with was someone who we were seeing for general weakness. She usually walks to and from meals, and they've been having to like wheel her occasionally. So during my session today, we did a lot of walking. She also has dementia, so like just cues and cue following is not very good for her, and so like transferring back to chairs required significant cues today with like getting her to actually turn with the walker and back up to her chair. She kept trying to sit prematurely, so we were trying to work on that. We did some seated exercises with some ankle weights and some bands, and then I tried to do some like standing balance with her in the hallway at the grab bar, but it was just not going well. I kind of had to stop that prematurely because her cue following, even with me trying to like help her and correct her, was not going well. So we discontinued that and just did a little bit more walking. Next person I saw is here skilled, so they're Part A. They were here for a stroke. The stroke actually didn't affect them physically too much. She's getting around and walking like up to 112 feet, I think was our distance today with the walker. standby assist, which means that I'm not holding on to them, I'm just by them for safety. Most of her stroke, I think, affected like her cognitive stuff and processing, so speech therapy is working with her. I don't think from a physical standpoint she'll need to be here very, very long, but then that's like when the cognitive component comes in of, you know, she was living at home, is it safe for her to go home, what kind of resources would she need, or do we need to look at a different discharge plan? So, but like from my perspective, she's not doing too bad. There's some like safety awareness issues that we need to work on, but overall she's doing well. Then I saw another Part B for a progress note. We are seeing her because she had a fall a couple weeks ago, and I think she's fallen a couple times since we've even picked her up. So we are working on lots of walking, exercises. Since today was a progress note, we had to redo some standardized tests. So I think I redid a tug or a timed up and go with her, and then a 30-second stand-up sit-down test. She also has dementia. Sometimes for the dementia patients with a standardized test, I will let them do a practice run at least one time, just because it's hard for them to like process and figure out the test just from me verbally or even visually explaining it to them. And so I did have her do the tug one time, and then I reassessed it, and she did it much faster the second time. So she's close to meeting that goal, not quite there. And then our 30-second stand-up sit-down test, she did meet that goal, so that was good. Timed up and go is a good test for like general balance assessment, and then 30-second sit to stand is a good like functional strength and muscular endurance test. Other things I looked at were, I think, how far she was walking before she needed to sit down, how much assist she needed when walking, transferring and standing, and then we did bed mobility as well because I needed to look at that. So mostly just seeing if she's on track for a goal, seeing if we need to upgrade or downgrade or modify anything. In that same hallway, this is a dementia hallway, I had another patient, Part B, that I was seeing who we're also seeing for falls. So with him, he was being a little bit of a stinker today and like not wanting to do anything with me, so it was like constantly me trying to like encourage him to participate. So we did some walking, we did like this functional like multiple repeated stand-up sit-down test where it works on like repeated sit-to-stands, repeated transfers, functional balance, because he's someone who also like takes forever to stand up and sit down from his chairs, and so like that's a safety concern for him too. Some of his falls have happened when he's going to like sit down in a chair and he just completely misses it, and that's like a good just like repeated practice activity where it's like the more that he does it, if we do it for like 10 minutes or so, then like by the end he's usually like standby assist like up and down pretty well. Today he was still standby, but he's just like, why are we doing this? And I was like, because I was explaining to him, but dementia, sometimes the explaining does not always, you know, follow through. Then I've got a skilled lady upstairs that I saw. She also has dementia. She broke her femur and then that had an intermedullary nail placed, so she's weight bearing is tolerated on that leg, and the biggest issue with her is pain limiting mobility, and then the dementia just like is confounded with how much she's wanting or willing to do in therapy. So she's a pretty heavy assist right now. We did walk for the first time since she's been here today. That was good, but like most of my session was just me trying to encourage her to like participate and do anything, because again, with like the combination of dementia and the pain, like she doesn't want to do anything. Had an eval for a Part B order to assess easy stand transfer safety. This patient is typically an easy stand with staff, but I think her like foot slipped last time she was in it and then like led to a skin tear. So therapy is assessing to see if the easy stand is safe for her to continue using, see if we can give any cues or pointers or work on anything to make it safer. I will say when I saw it today, it was not looking very good, so we're definitely picking her up to work on that, either making sure she can tolerate the easy stand and like improve her strength and standing tolerance for that, or if it doesn't go well, then we would need to downgrade her to a Hoyer. So time will tell for that one. We'll have her on for a couple weeks probably. Oh, I had another skilled person. He just came yesterday. He's pretty high level already. He's mostly just waiting for his apartment on campus to open up because he's moving to the assisted living apartment, and he just needs to like get moved in, and so he's here in the meantime. But he is standby assist to supervision with his walker. We did the new step. We did this tic-tac-toe activity for balance. We had him standing on the RX foam, and then we did some walking inside and outside, and that was most of what I did with him today. Had another skilled lady. She is here after falling and then breaking her wrist, or she's not weight bearing on the wrist. I think it's probably broken. And then she fractured some of her vertebra. So she's supposed to be like non-weight bearing, wearing a sling, and then have a TLSO or a thoracolumboSacral brace. She does not like wearing those, but we got him on. She walks without a walker, so most of my session today was us going for a walk. We went outside, looked at the garden. Sometimes with dementia patients, getting them to engage in activities that they are interested in is the best way to get them to participate. And so she liked the flowers, was very pleasant during a session. We have worked with this lady before, and like historically she's like really not liked therapy, so just trying to get her to participate in a way that's meaningful for her. And we did lots of walking outside. It's good for balance. And that was most of what I did with her today. And then I was supposed to have a group of 3 today. One of the people has been out of the facility all day at an appointment, so I had to miss their visit. And then I did a group of 2. We just did an exercise group because, quite frankly, that's all my brain had in me at the end of the day. And I was kind of keeping my options open because the 3 people that were supposed to be in a group were like varying levels of abilities, and exercises can be titrated up or down based off of what people can do. So just a basic exercise group. So we adjusted weights and stuff for people, and I think that was my day. I just double checked my schedule, and that was in fact everyone. So now it's 4:53 and I am going home.
When we do these videos, we tend to, I feel like, have the mindset of we're home, we're off the clock. So this video is over. So if you guys want to know what we do after work or, you know, in the evenings, we've got many other vlogs on our channel.
We've got some specific like after work vlogs. We've got some morning vlogs. We've got some
so check those out.
Vlogs.
I'm honestly probably just going to try and start editing this video this evening. So we're gonna wrap it up here. Hopefully you guys enjoyed. You guys tend to like these videos, so gives you a little bit more insight to what we're doing.
Yeah, because we're not able to always, we don't always discuss in depth like what our workday looks like, aside from maybe a few highlights. So these are fun to like go more in depth. I know some people do follow us like specifically for PT related content, and they like when we share more of that information.
So make sure you subscribe if you're not already, and we will see you guys in our next video. Bye.